So, good evening, all. Welcome to Smart Road Academy. Myself, Cheryl from Medical Surgical Nursing. So, today we are going to discuss about heart block and ventricular arrhythmias. Okay, so in a previous class, we studied about the basics of ECG and atrial arrhythmias. Okay, so this is also a class about ECG analysis. It is mainly about ECG analysis, and we will be discussing the theoretical part of this heart block and ventricular arrhythmias also. Along with that, we will be doing ECG analysis. Okay. So before going to the condition, as usual, we will discuss some basic facts, then we will go to the condition. Okay, so as you all know about the anatomy and physiology of the heart, but just I am refreshing. Okay, in case of any doubts, you can ask in between. You can put it in the chat box. Okay, so as you all know, the deoxygenated blood from all parts of the body will be carried by IVC. Here all the parts are marked, IVC and SVC, to the right atrium. Okay, so the deoxygenated blood get into the right atrium, and from the right atrium it is ejected to the right ventricle, and in between there is tricuspid valve, and from the right ventricle the blood will be going to the pulmonary artery. Okay, so one question you can expect, that is the artery in human body which carry deoxygenated blood. The artery in adult human body which is carrying deoxygenated blood, that is pulmonary artery. If the question is like the artery which carry deoxygenated blood in fetus, it is like what? Umbilical artery. Okay, so you should remember this. If they are these two are the arteries which carry deoxygenated blood. Okay, this is in fetus and this is in adult body. So this deoxygenated blood is carried by the pulmonary artery to the pulmonary vasculature, that is to the lungs. Okay, so in the lungs, this blood gets oxygenated, and this oxygenated blood is coming to the left atria through what? Through pulmonary veins. So this is also a question, the veins which carry oxygenated blood, pulmonary veins. Okay, so through the pulmonary veins, the oxygenated blood gets to the left atrium, and from the left atrium the blood is going to the left ventricle, and in between the valve is bicuspid valve or mitral valve. Okay, so this is the valve in between. In between pulmonary valves are there, and from the left ventricle the blood is going to the aorta. You can see the aorta here, and in between what is there? Aortic valve is there. Okay, so this is about the functioning of the heart, and with each heartbeat this function is happening in the body. So thus our transportation of blood to all parts of the body is happening with each heartbeat. So with each heartbeat, what all events are happening in our body? So that is known as cardiac cycle. The events which is happening in the heart in one heartbeat or in each heartbeat is known as cardiac cycle. Okay, so this cardiac cycle, one cardiac cycle will take how much time? It is 0.8 seconds. Okay, one cardiac cycle will take 0.8 seconds. So this is just about refreshing your knowledge. Okay, so basics should be strong so that you can study the disease condition in a very well manner. Okay, so before studying about this cardiac cycle, we should know some basic principles. Let's see about that. The basic principle are, first one, blood flows from higher to lower pressure. So where the pressure is high, from that area to lower pressure, the blood will flow. And the second point is, excuse me. So contraction increases the pressure and relaxation decreases the pressure within the chamber. Okay. So if the contraction is happening in a chamber, then the pressure will be increased in that chamber. And in case of relaxation, the pressure within the chamber will decrease. For example, this ventricular contraction is happening. So at the time of the contraction, the pressure inside the chamber will be very high. And in case of relaxation, the pressure will be less. Okay. So you can compare it with human conditions also. If the pressure is in contraction, or if you are doing some activities, we are stressed out, then the pressure will be high. In a relaxed state, the pressure will be less. Okay. So then the next third point is valves open according to the pressure gradient. So I already told you about the pressure gradient. So according to this pressure gradient only, the valves will be open. So how it will be happening? That is, if we can take the condition of left atria and left ventricle. So in between, mitral valve is there. Okay. So when the blood is, if the left atria is contracting, contraction of the left atria is happening, that means increased pressure will be there. Okay. So then left ventricle, what will be there? Decreased pressure in left ventricle. So for opening of this mitral valve, the left atrial pressure should be more than the left ventricular pressure. So if it reaches the maximum level, that is the left atrial pressure increased to a level in which it is much more than the left ventricular pressure, at that time this mitral valve opens and the blood is ejected to the left ventricle. So in this way, all the valves will be working. So let's see the cardiac cycle now. So I already told the cardiac cycle. One cardiac cycle takes 0.8 seconds, and the cardiac cycle is mainly divided to two parts, that is systole and diastole. Okay, contraction and relaxation. So this is happening in the cardiac cycle. So according to the atria and ventricle, it is again divided into 6. So first you can see the atrial contraction. You know about the cardiac contraction. We will again discuss it anyway. But according to the cardiac contraction, first what will be happening? The SA node fires and the atrial contraction happens. Okay, or the atrial systole begins here, or atrial contraction is happening. So in atrial contraction, when the atria is contracting, the blood will be ejected out to the left ventricle. Fully the atria will contract and all the blood from the atria comes to the ventricle. Okay. So the next phase, so the atrial systole ends and the ventricular systole starts. So this is known as the first phase in ventricular systole is isovolumic or isovolumetric contraction. In this, what will be there? After filling in of the blood, the ventricle starts contracting. Okay, listen well, that ventricle starts contracting. So it is only started so that the pressure is increasing, not increased to a level to open the valve. So the valves are closed here. In this phase, the valves are still closed, but the ventricle started to contract and the pressure is started to increase. Okay, so that is isovolumetric contraction. And the next phase, that is ventricular contraction. This phase is also known as rapid ejection. So in this name, from the name also you can identify that rapid ejection of the blood from the ventricles to the pulmonary artery or to the aorta will be happening here. So rapid ejection, the valves will open and the blood will be going out to the aorta or the pulmonary artery. Okay, so that is the rapid ejection phase. Then the ventricular ejection. This is also known as reduced ejection. This is known as reduced ejection. So in this, what will be happening? Some more blood was also there that will also go out, and the valve, the semilunar valve. What are semilunar valves? Semilunar valves are aortic valve and pulmonary valve. So these two are semilunar valves. So those valves will close and it makes which sound? S2. And when the AV valve close, that will make S1, the first heart sound, and the second heart sound happens by the closing of semilunar valves. So that is known as ventricular ejection. So by this three, the ventricular systole, that is the ventricular contraction, ends here. Next, we are moving on to atrial diastole. So atrial diastole means relaxation of the atria. So that is known as isovolumic or isovolumetric relaxation. In this, ventricular early diastole is also happening. Ventricle is also started relaxing here. And in this phase, atria is filled with blood. Atrial filling will be happening in this phase. And the next phase, you can see ventricular filling. So in this, what will be there? The ventricle will be started filling. It's not like the atria is fully contracted. The valves are open and the atria is started filling in a very less amount. The ventricle started filling. This is known as ventricular diastole. This is the relaxation phase only. So after that, the atrial contraction, we already said about atrial contraction, the blood will totally ejected to the ventricle. So this cycle repeats with each heartbeat. We explained in a very big manner, but this will be happening in a very rapid way. That is the normally 0.8 seconds. So this cycle is happening with each heartbeat. Okay, so this is about the cardiac cycle. If you are feeling difficult to understand, you can again read it in the image itself. It is written. Okay, so this is about the cardiac cycle. We also discussed about the basic principles in cardiac cycle. Next, we are moving on to the cardiac conduction that is needed in our studying our disease condition. So I'm not going into detail in the cardiac conduction system in detail. We learned in the first class, that is the ECG analysis. Okay, so just I'm refreshing only. The parts are the first one, sinus node, is the pacemaker of the heart. From the sinus node, it is passing on to the AV node. From the AV node, so AV node is acting as an electrical gateway that the impulse is passing on to the ventricles with the AV node only. So from the AV node to the bundle of His, then right bundle branch, left bundle branch, then Purkinje fibers. So how the repolarization, depolarization is happening already explained in the first class. You can even refer that also. So just I am going fast. So and today we are studying about the AV block. Okay, so we studied that in sinus node, if the sinus node is started conducting electrical impulses, the impulses will travel to both the atria. So that what will come in ECG, this phase will come as P wave. Okay, P wave will come in this phase. Okay, then from P wave, so from the sinoatrial node, the electrical impulse is traveling to the AV node. So there is a delay after this P wave. There is a small delay. A small delay will be happening while traveling from the electrical impulses from sinus node to the AV node. There is a small delay. So this is after P wave, there is a small delay. Then the QRS complex denotes the ventricular electrical activity. So this small delay is happening here. So normally, so in AV block, what will be happening? This delay will be more, or some block will be there in this pathway. Okay, so that the electrical conduction may not be happening, or it will be delayed. or it can cause some rhythm abnormalities. Sometimes it will, after due to this block, it will take some time to reach here. Sometimes it won't reach at all. So according to that, the degree of block varies. Okay, so according to that, the heart block types will vary. So this area is known as the PR interval. PR interval in the ECG. Okay, from the starting of the P wave to the starting of the QRS complex is the PR interval. So normally this PR interval is the time period, the normal time period or the duration of the PR interval is 0.12 to 0.20. Okay, so this is the normal time duration of this PR interval. So sometimes in AV block, in first degree AV block and all, this will be delayed, that is more than 0.20. And in other type of blocks like second degree or third degree or complete heart block, the conduction is not happening at all. Okay, so we will see in detail so that it will be more clear to you. First, let's see what is AV block. So atrioventricular block is an interruption or delay of electrical conduction from the atria to the ventricles due to conduction system abnormalities in the AV node or the His Purkinje system. So there is some conduction abnormalities in the pathway, so that the conduction is not happening properly. So that is known as atrioventricular block. From the atria to the ventricles, the conduction is not happening properly. That is known as AV block. So the AV block is broadly divided into three types. That is first degree AV block, second degree AV block, and third degree AV block. So first degree is there. Second degree is again divided to Mobitz type 1, Mobitz type 1 and Mobitz type 2. Okay. Then third degree, that is known as complete heart block. Third degree is complete heart block. So let's see what is first degree block. So first let's see the etiological factors. So first one is fibrosis or sclerosis. So this heart is functioning from our birth. So according to the mechanical activity, at some point the heart will undergo some fibrosis or sclerosis that can cause this conduction abnormalities. Then CAD, coronary artery disease, can obviously cause this conduction abnormalities. Then some drugs. So the examples are, it is not like with first use it will cause, with continuous use, the beta blockers or the calcium channel blockers can cause conduction abnormalities. Then the vagal tone means decreased vagal tone. Decreased vagal tone can increase the PR interval and can cause the AV block. Genetic disorders like some congenital heart disease can interfere with normal conduction. Then illnesses, example is above only CAD. Then electrolyte imbalances can affect the conduction, like potassium, sodium balances will especially affect. Then calcium, these all will affect the the abnormalities or the imbalances in the sodium, potassium, calcium. Mainly these three will suddenly affect the conduction of the heart. Next, any heart surgery. So these all will lead to heart block. So first degree AV block. First degree AV block is a condition of abnormally slow conduction through the AV node. It is defined by ECG changes that include a PR interval of greater than 0.20. The normal is from 0.12 to 0.20. So the time period is more than 0.20, then we will call it as first degree AV block. But no other abnormalities will be there in first degree AV block. Only the interval is little more. but the rhythm will be regular, the contraction will be happening normally, and this delay will be there in all the leads. Same delay will be there in all the leads, no other abnormalities, no rhythm change, so that in first degree AV block, mostly the patient will be asymptomatic. Okay. So here also it is written like without disruption of atrial to ventricular conduction. Conduction is happening. Some small block is there. That is first degree block only. So some small block is there. So the delay is happening, but the conduction is anyway happening. So that the patients won't have any symptoms. Okay. So we can see the ECG. So this is the first degree AV block. So we can compare it with some normal ECG. So this is a normal ECG. Okay. Can you able to appreciate? Because in P wave, after P wave, a small delay is only there. You can see in every leads, a small delay only is there before the QRS complex. But here you can see on allo is also there. After the P wave, a prolonged delay is more here. But this delay is consistent in all the leads. And anyway, the conduction is happening and no other abnormalities present, so that the patient will be asymptomatic. So you can compare it with both that, so that you can identify this one. The gap will be more in first degree AV block. So this is not a serious condition, but as the block progresses, the patient's condition will worsen. So this is the next one, that is second degree heart block. I already said the second degree heart block is divided into again two. First one is Venn-Gay batch or Mobitz 1. So this you can remember, Mobitz 1. Okay. So Mobitz 1, how can we identify whether the patient is having Mobitz 1? So you can see the ECG here. So this is explaining it more clearly. P waves and QRS complex are looking normal. The base structure will be normal only. Morphologically it is normal. The PR interval progressively lengthens and dropped beats will be there, leads to grouped beating. The block is almost always within the AV node. So you can see in the ECG, in Mobitz 1, the thing is like the P wave after this delay, no, this is small here. Then it is little elongated here. Little elongated here. Then it is more elongated. Then one beat is dropped here. Okay. So you can see that the interval will elongate. So the interval is progressively lengthening which each leads. And finally, one P wave won't conduct. That means with one P wave, one QRS complex won't be there. That what do you mean by that? That means if one P wave is there and with the P wave, if QRS is not there, that means from the atria, the impulse doesn't pass to the ventricles. So that is the meaning. So this gap progressively lengthens and one P wave, that means the one P wave won't conduct at all. That means here the conduction, the electrical impulse doesn't pass to the ventricles. Okay, so I will show you again an ECG so that you will understand more. So here this is a normal ECG and this is the Mobitz type 1. Mobitz type 1. So here you can see it is marked also. The interval is lengthening and finally one P wave won't conduct. Then after some gap, again this cycle repeats. So this is known as Mobitz type 1, in which successive prolongation of the PR interval until a P wave is completely blocked. Again the cycle repeats. So this is known as Mobitz type 1. Next one is second degree AV block, that is Mobitz type 2. Okay, so in this what will be happening? The ventricular rhythm is irregular and atrial rhythm is irregular. Okay, the patient will be mostly bradycardiac. Okay, so bradycardic, that means the patient will be having heart rate less than 60. So patient is symptomatic here. So this is known as Mobitz type 2. This is also second degree heart rate. So regular P waves with a regular PR interval is there, and occasional dropped QRS complex is the most identifiable characteristic of second degree AV block. So if beats are frequently dropped, the cardiac output can be compromised. So if the conduction is not happening properly, the cardiac output or the ejection of blood is not happening properly. So that what will be happening, patient will be having shortage of oxygen supply to the tissues, that will leads to symptoms. Okay, so mainly the symptoms of this heart block is syncope and angina. Why syncope is happening? Syncope is happening when there is decreased blood supply to the brain. Decreased blood supply to brain. So that syncope is happening. Angina, why it is happening? If the cardiac output is compromised, the heart itself won't get blood. The myocardial muscles, there will be decreased blood supply. So what will happen? Angina, chest pain will happen. So these are the two main signs of this heart block. Okay, so usually treatment is not needed. If symptomatic bradycardia occurs, then transcutaneous pacing. Transcutaneous pacing means temporary pacemaker we will insert and we will see. So that will be the first choice. Atropine we won't be giving, because sometimes atropine can worsen the AV block also. Atropine may be used, but with caution only we will be using. The first choice will be anyway temporary pacing. Okay, so this is about the second degree AV block. So let's compare. This is an healthy ECG. Okay, so here you can see normal P wave, normal PR interval. So this is a healthy ECG. And Mobitz type 1, you can see the PR interval are gradually elongating until a P wave is completely blocked. Here you can see small, much bigger than the P wave is completely blocked here, and the cycle continues. This is Mobitz type 1 of second degree. Then Mobitz type 2 of second degree, what will be there? The PR intervals are consistent, but some P waves won't contact at all. That means what will be there? Here the elongation is happening. So we know that elongation will happen and one P wave won't contact. But here we cannot say anything. So the PR interval is normal. But wherever the P wave is contacting, the interval will be same only. It is no elongation is happening. But somewhere the P wave is not conducting at all. Here it is conducting with normal PR interval. Not normal, maybe elongation is there, but it is same everywhere. No elongation is there. In every leads, the PR interval is consistent. But in between the P wave won't conduct. Then again it is happening. Here again the P wave is not conducting. So we cannot expect where the conduction happens, where it won't happen. So it will be much difficult in type 2. So a Mobitz type 2 is more severe than Mobitz type 1. So usually in first degree heart block and second degree type 1, the treatment is not that much needed. And in Mobitz type 2 also, we won't give much treatment until and unless the patient is having bradycardia or other symptoms. Okay, so this is about the first degree and second degree heart block. Next, third degree AV block or complete heart block. So this is a severe condition in which the patient's conduction system is totally damaged and the patient is having severe bradycardia. So that what will be there? The patient, the sinus rhythm, the pacemaker and the permanent pacemaker will be needed for the patient in third degree AV block or complete heart block. So the thing, in sinus rhythm with complete AV block, the PP and RR intervals are regular, but the P wave has no relationship with R wave. In complete heart block, the thing you can see is complete dissociation. Complete dissociation between P and QRS. Okay, so that means somewhere P is coming and somewhere the QRS complex is coming. There is no relationship between the P and QRS. Okay. So usually what should be there? With one P wave, after one P wave, one QRS complex should be there. But in complete heart block, well, after one P, it is not necessary that the QRS complex will come. One P, another P will come, or some gap will be there. So there won't be any relationship between this P and the QRS complex. The PR interval varies because there is no really P and QRS relationship. The ventricular rate is usually 40 to 60 beats per minute. Okay, 40 to 60 beats per minute, and narrow when it is driven by junctional pacemaker, that is AV node. So the SA node stops working here. So the AV node is functioning. So that will generate, that cannot generate impulses as good as the sinus node. So 40 to 60 beats per minute only will be there. The QRS is wide and less than 40 beats per minute when an infrahisian pacemaker takes over. Okay, so this is about the complete heart block. So you can see 4 ECGs here. So try to interpret this. In first degree, what is there? The intervals are consistent. The only thing is the PR interval is more. That is more than what? More than 0.20 seconds is there. But everything is normal and no rhythm changes here. Everything is good. The patient will be asymptomatic in first degree heart block. In second degree heart block type 1, that is Venke patch or Mobitz 1, what will be there? Progressive elongation, progressive prolongation of PR interval, and one P wave will be dropped. One P wave won't conduct, that is drop the QRS complex is there, then again the cycle continues. That is in Mobitz type 1. In second degree heart block type 2, what will be there? One P wave won't conduct, but the PR interval is fixed here. You can see between every P and QRS, there is fixed PR interval. But somewhere the P wave won't conduct. So we can't say that where it will conduct and where it won't conduct. Here we can say after some prolongation, it won't conduct. So here the P wave, the P and QRS is having some relationship. There is fixed PR interval, but somewhere the P wave won't conduct. That is Mobitz type 2. Then the third degree heart block, here you can see the QRS is coming. After that one P, after that some other P, small P, then one gap, then QRS. So they here complete dissociation. Regular PP intervals unrelated to regular RR intervals. Okay, so this is known as third degree heart block. So I think you guys are clear with it. So if you can't understand, if you are feeling difficult to understand, you just again and again see the ECGs so that it will be clear for you. So this is the treatment for first degree. The PR interval is constant. The symptomatic treatment, we won't give any treatments actually. We'll just observe the patient only so that whether it is progressing or not. In second degree block, the treatment we won't be giving treatment in type 1. But in second degree block type 2, we will be providing temporary pacemaker mostly. First choice will be temporary pacemaker. If the patient is, the bradycardia is not maintaining even after temporary pacemaker insertion also, then we will go for permanent pacemaker. In third degree heart block only, the only choice is what? Permanent pacemaker only. Okay. Ventricular arrhythmias. These originate from cells in the ventricular muscle mass or the Purkinje fibers. So these arrhythmias will originate from the ventricular mass. Considered as the most dangerous and life-threatening arrhythmia. So you should know that the most dangerous and life-threatening arrhythmia mostly will be in ventricular arrhythmia. Okay. Then due to their effect upon ventricular contraction, they can severely reduce cardiac output. And if cardiac output is reduced, what will be there? Obviously, the patient won't be getting enough oxygenation. Okay, the patient won't be getting enough oxygenation, that can lead to different problems. Okay. Then premature ventricular complex is the first ventricular arrhythmia we are going to discuss. So what is premature ventricular complex, or what is happening in this type of arrhythmia? Ventricular premature complexes occur when the ventricles contract before they should. Okay, so in this condition, what will be there? There is a time period for the conduction to happen. First the SA node, then to the AV node, then AV node to the bundle of hairs, so that the contraction and relaxation is maintained in a fixed intervals. So in premature ventricular complex, when it will be happening, there is a time period for the ventricles to contract. So before that time period, the ventricles will contract, and that is not a proper contraction. It is a premature contraction. Okay, so that all the blood won't be ejected out well, so that again one contraction also will happen. So one premature contraction will happen first, then the proper contraction. Okay, so this premature complexes occur when the ventricles contract prematurely. When this happens, the heartbeat becomes out of sync. Okay, so the all these activities are properly synchronized, and when this premature contraction happens, the heartbeat becomes out of sync, obviously. Then patient may feel a regular heartbeat. So what patient will feel here? A regular heartbeat, an extra heartbeat, and a pause, and then a stronger heartbeat. So can you able to appreciate what is this? For regular heartbeat, normal heartbeat is happening. Then one extra heartbeat. Here what will be there? The premature contraction happens. So some extra heartbeat. Then a pause will be there. And this is known as a compensatory pause. Then a stronger heartbeat. That is the proper ventricular contraction. So this is happening. The extra heartbeat is the premature ventricular complex. But it isn't as strong as a normal beat, and it doesn't pump all of the blood out of the heart because it is premature contraction. So it cannot, it won't be strong as the normal beat, so it cannot pump out all the blood. This causes the heartbeat that follows to be stronger because more force is needed to pump the extra blood out of the heart. So this is the thing happening with when we are seeing premature ventricular complex in ECG. Okay. So let's see how the ECG looks like. So this premature ventricular contractions occur earlier than the next expected QRS. So there is a time period in which we will expect the QRS. That is 1P, 1QRS complex, then the T wave, then again 1P. I'm just drawing like this. So this is happening like in a synchronized manner, no? After some time period, this will be happening. So in what will be there before the expected? So we are expecting one QRS complex after a fixed interval. This won't be there. Before that, when we are expecting the QRS complex, this premature ventricular complex will appear. So this premature ventricular complex, we can see the morphology. This is wider than the usual QRS complex. So it will be bizarre. The morphology of the QRS will be bizarre. Not a proper QRS complex. And the preceding P wave. So usually before a QRS complex, one P wave should be there. So in this, what will be there? Preceding P wave absent. Preceding P wave is absent. You can see in the image itself. And deflection of ST segment and T wave is opposite that of the QRS, followed by a compensatory pause before the next conduction happens. Okay, so here you can see the P wave, the QRS complex, V wave normally happening. Then again, premature complex here. So will be this premature complex will be shown as a wider QRS complex. The QRS morphology will be bizarre here, and the preceding P wave won't be there, and a compensatory pause sometimes you can observe. So if you are seeing like this, this is known as premature ventricular contraction. Okay. So that is premature ventricular contraction. So what are the causes? Why it is happening? Use of caffeine, nicotine, and alcohol can cause PVC. Cardiac ischemia or infarction. Increased workload for heart, that is exercise, fever, hypervolemia, heart failure. This doesn't mean that those who are doing exercise, everyone will be having, not like that. If the patient is having not having proper maintenance of heart, already the patient is having some heart disease or decreased tolerance, and the patient is doing exercise, that will cause increased workload for the heart and it can cause PVC. Then digitalis toxicity. I already said when we are saying, when we were discussing about digoxin toxicity in the last class, the digitalis toxicity, the ACG finding mainly will be appearance of premature ventricular complex. Then hypoxia can be a reason, acidosis can be a reason, and electrolyte imbalances like I'm so sorry for the interruptions in between. So we are continuing. So in causes of PVC, the electrolyte imbalance, example, hypokalemia. And hypokalemia also, the PVC can appear. Okay, so in hypokalemia, PVC can also appear. One more thing in hypokalemia is appearance of U wave. Okay, then ventricular tachycardia is the second one. Ventricular tachycardia. So this is caused by rapid firing from ectopic foci and results in rapid impulse propagation in ventricles. Rapid firing from ectopic foci. So ectopic foci, that means there are, you know that the conduction system consists of the normal parts like SA node, AV node, bundle of his and Purkinje fibers. Okay, so other than this, some ectopic areas that will rapidly causing firing or electric impulses will be generating from this other areas other than this conduction system. Some other areas are generating the electric impulses. This is known as ectopic foci. Okay, so this areas will generate some other areas other than the conduction system will generate rapid firing or generate the electrical impulses, results in rapid impulse propagation in ventricles. Okay, so other than the normal conduction system electrical impulse, some other areas are also generating electrical impulses, resulting in rapid impulse propagation. So that will cause the ventricular tachycardia. So it's defined as 3 or more PVCs in a row occurring at a rate exceeding 100 beats per minute. So from the word itself, you can see that there is a tachycardia. That means the rate will be higher, more than 100 beats per minute. Okay, so you can see even PVC, we already studied how the morphology is. So in ventricular tachycardia, there will be 3 or more PVCs in a row. Okay, and also the heart rate will be higher, more than 100 beats. Usually associated with CAD and may precede VF. Okay, so after if we are not treating this ventricular tachycardia properly, then it can lead to ventricular fibrillation, which is a very fatal, or it is the most lethal arrhythmia. Ventricular fibrillation is the more lethal. That means life-threatening arrhythmia is ventricular fibrillation. So if ventricular tachycardia, if we are observing, we should treat it very well. Otherwise, it can lead to ventricular fibrillation, which is most lethal. So ventricular tachycardia is an emergency because patients will be usually unresponsive and pulseless. So what we will give, defibrillation shock, we will give immediately to the patient according to the protocols. So this is the ventricular tachycardia. So I think you guys are can able to appreciate, I think, because you can see that there is no P wave. So here you can see P wave can be present, may not be present. So I think in this, no P waves are here. You cannot see a P wave here. And there is no set relationship to the QRS. If P wave is present or something is happening here. No. So some P wave like that, some morphology is here. So if P wave is present also, that P wave will not be having any relationship with the QRS complex. And the PR interval, we cannot able to appreciate here. Then the QRS complex obviously less than 0.12 because tachycardia is happening. QRS rate will be 100 to 250 beats per minute, and QRS rhythm will be regular. Okay, so here you can see the there is no P wave and the PQRS relationship won't be there. And even the QRS complex is also a bizarre morphology for the QRS complex also. Just the hype is happening, but the prescribed morphology for a QRS complex is like some negative deflection of Q, then one positive deflection for R, then the negative deflection for S. So like that, we cannot able to appreciate in ventricular tachycardia. So that is about ventricular tachycardia. So if you can even get questions like description of the condition of the patient or the ECG characteristics, they can give us a description and then they can ask what is the abnormality in the ECG. Or they can ask like or they can show you the image of the ECG and then ask the question, what is the abnormality here? Or they can ask about the intervals, the time period of the intervals, or in some conditions these arrhythmias are especially present. So in all these ways you can get questions. So you should be clear with even identifying from the ECG, and also from the theoretical part you should be good. Okay. So in the last class, we discussed about this atrial arrhythmias, sinus arrhythmias, and all. Okay, so in that I forgot one point, like in athletes or in sports person, one conduction abnormality will be present. Do you know what is that? In athletes, one conduction abnormality is present, that is the sinus bradycardia. So this is a question in one previous competitive exam. One question was this one, that is in athletes which arrhythmia is common, that is sinus bradycardia, but this is not an abnormality in them. Okay, in sports person or in athletes, sinus bradycardia will be present, but this won't be a abnormality in them. In this, what will be there? This is a healthy adaptation for them. So they will be doing vigorous physical exercises. So this will normally their heart will adapt to those exercises, and with limited or decreased heart rate, the normal stroke volume or normal amount of blood will be ejected from their body, and that will be sufficient for their body. So this is a healthy adaptation for them, not an abnormality, but we can see sinus bradycardia with normal rhythm. Bradycardia will be present for athletes. Okay, so this point also you should remember. Then we are moving on to ventricular fibrillation. That was just a point. I remember that, so I just told you. So this is third one, ventricular fibrillation. So this is the last ventricular arrhythmias. So it's a rapid but disorganized ventricular rhythm that causes ineffective emptying of ventricles. Okay, so this is totally a disorganized ventricular rhythm. The rhythm will be irregular and there won't be effective emptying of ventricles. There won't be effective emptying of ventricles, so that obviously the cardiac output will be affected. The body won't be getting adequate blood. There is no atrial activity seen on the ECG. Okay, no atrial activity can be seen, or just the ventricle is just fibrillating. No proper contraction is happening. So on the ectopic foci, just the ventricle is fibrillating. No proper contraction and relaxation is there. So the blood won't be ejected out from the body, and there is no atrial activity can be seen. Atrial activity is represented by which one? P wave. So no atrial activity. That means no P wave in the ECG. It can progress from a coarse to a very fine tracing. Later is less likely to be terminated by defibrillation and therefore necessitates treatment at the earliest opportunity. Okay, so I already said the most lethal arrhythmia is the ventricular fibrillation. So when it reaches the peak, we cannot even, with the help of the defibrillator also, we cannot revive the patient. So when the ventricular tachycardia appearing also, so when the ventricular tachycardia appearing itself, we have to give the defibrillation or the shock according to the advice of the doctor. So if we are not giving that a time, if the ventricular fibrillation reaches its peak, we cannot revive the patient and sudden death can happen. So for the earliest opportunity, we have to treat this ventricular fibrillation. So this is the ventricular fibrillation. So here you can able to appreciate. I think you guys can able to appreciate that there is no P wave, even no QRS complex, no proper morphology for the waves. The waves are completely disorganized. Immediate cessation of the cardiac output. No associated pulse. The patient will be pulseless. No discernible P waves, QRS complex, T waves, incompatible with life. It is a life-threatening arrhythmia. Okay, so this is about the ventricular arrhythmias. I think you are clear with it, even the ECG analysis and all. So let's see the ECG of ventricular arrhythmias. So here you can see the first ventricular arrhythmia. This is the premature ventricular complexes is appearing. So what is the, I'm just summarizing. So in this you can see the preceding P wave is absent and the morphology of the QRS, the complex is wide. Okay, and the bizarre morphology is there. Then the normal beats, again the PVC is appearing. So this is premature ventricular complex. Next one is VT, ventricular tachycardia. No P waves are there. Okay, even the QRS is also having bizarre morphology. Then next one is the VF, ventricular fibrillation. Here no P wave, no in VT and VF also. In both no P wave is there. Even QRS is also not there. In some hike is there in VT in here. No QRS is also not there. No T wave, nothing is there. Complete disorganization, and this is the most lethal arrhythmia. If you are getting a question like the most lethal arrhythmia, that is the ventricular arrhythmias, or the most life-threatening arrhythmia is the ventricular, not ventricular arrhythmias, ventricular fibrillation is the most lethal one. Okay, so this is the end of the class. So I am going to ask some questions. Kindly put your answers in the chat box. So this is the first question. A patient's monitor showing sudden change in rhythm with no P waves, wide QRS complex, heart rate over 100, but rhythm is regular. Determine the patient's condition. So you can see here, no P waves. P waves are not present. Wide QRS complex is there, and heart rate is over 100, but rhythm is regular. Determine the patient's condition. First option, ventricular tachycardia. Option B, ventricular fibrillation. Option C, premature ventricular contraction. And D, atrial fibrillation. So, yeah,
Ventricular tachycardia.
Yeah, the answer is correct. Ventricular tachycardia. Okay. So why? So you can confuse with this if it is like wide QRS complex. You can confuse it with this premature ventricular contraction. Okay, but you have to see no P waves. Okay, so you have to read the whole question. So in PVC, wide QRS complex is there, but no P waves, no P waves. Okay, so if in premature ventricular contraction, a wide QRS complex is there, but P waves will be present. So that you have to see the. Okay, so in ventricular tachycardia, all the criteria will be coming, and you can confuse this with atrial fibrillation also. In atrial fibrillation also, what is there? No P wave. In atrial fibrillation also, P wave won't be there. So what we will be doing? So can you please unmute yourself? Sorry, can you please mute yourself? So in atrial fibrillation also, P wave is not there, but you have to see the other criteria, the wide QRS complex and all, and the rhythm won't be regular in atrial fibrillation. Okay, so you have to read the whole question before answering. Okay, the options anyway will be confusing. Okay, so let's move on to the next question. Normal duration of PR interval. The normal duration of PR interval. First option 0.21 to 0.30 seconds, B 0.20 to 0.28 seconds, C 0.12 to 0.20 seconds, D 0.18 to 0.21 seconds. Yes, Sharada, Devi and B Komadi, both of you answered correctly only. 0.12 to 0.20 seconds is the answer. 0.12 to 0.20 seconds. Right answer. Next one is the third question and the last question. I think I already just now later. Cardiac conduction abnormality commonly seen in athletes. A. Atrial tachycardia, sinus arrhythmia, sinus tachycardia, sinus bradycardia. Which cardiac conduction abnormality is commonly seen in athletes?
Sinus bradycardia.
Yes, your answer is right. All of you answered. I think both of you answered. So your answer is right. That is sinus bradycardia. So these are few questions only. So like this way you can expect question. Even I put 3 types of questions. Okay. So the condition they can give, or they can ask some common theoretical questions, and I didn't give you image-based questions, so that you need more practice for answering the image-based questions. Okay. So this is about the class. Thank you everyone, and try to practice with more ECGs so that you will be experts in it. Okay, so if you are practicing, you will be able to interpret every ECGs. Okay, thank you everyone.